Good afternoon. Thanks for being here, and thank the organizers for inviting me. So today I'll be discussing how unconscious bias impacts patient care. Let's see here. All right, all right. So the first thing I wanted to discuss is the implicit association test, only because I will refer to this a lot in my talk. So as Dr. Quezada mentioned, this is a test I think everyone should take. It's a test where you associate positive or negative terms and with certain images, and the images can be based on race, gender, weight, and it gives you a number, and depending on the number, it tells you that you have a mild, moderate, or high level of anti-white, pro-white, anti-black bias. So in my institution, just to follow suit, everyone has to do unconscious bias training. We had it during the grand rounds, and we had a case of a patient with Crohn's disease, and we all got the exact same case. We got divided into small groups, and we had to discuss treatment and management of this case. We then had a large group discussion discussing what we did. And while most of us were pretty congruent, we definitely had some people who had differences in opinions. And during the course of the discussion, what came out were terms such as drug seeking or non-compliant patient. So we as a department or division had a very nice conversation around that particular assumption and why we made those assumptions. So what I would recommend is, and to follow suit, is actually take that test and do it every once a year, because you might be surprised at what you find in terms of your own implicit biases. So just to go into, so as physicians, what do we believe about ourselves? Number one, all right, I think I'm having technical difficulty. So number one, we believe that we're socially conscious. We believe that bias would never affect our patient care. And most of us, honestly, we went into medicine because we wanted to help people. However, we know healthcare disparities do exist. We know that there's a higher morbidity and mortality in underrepresented groups for certain diseases, such as heart disease, diabetes, certain malignancies. We know that from prior studies that race and gender can influence management of chest pain and referral for cardiac catheterization. And in the VA system, which is everything is created equal, same access to care, we have found that Black veterans are undertreated for pain due to osteoarthritis. They are less likely to be offered a laparoscopic cholecystectomy. They're less frequently treated with revascularization for heart disease. And being Black and Hispanic is an independent risk factor for amputation and PVD, even more so than a history of gangrene. Specific to GI, if you look at liver transplantation, looking at the 2017 transplant rate, this is more than 20% lower for Hispanics and Asians. And if you're looking at women are 30% less likely to undergo a liver transplant. And looking over the past few years, if you're looking at patients who are transplanted for severe alcoholic hepatitis, mostly male, mostly Caucasian, and mostly with private insurance. So the question becomes, do we have implicit biases as physicians? In 2002, the Institute of Medicine did a report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. This was done at the request of Congress, and they specifically asked them to assess the extent of racial and ethnic differences in the quality of healthcare that were not attributable to access to care, ability to pay, or insurance issues. They had a few key findings. They found that even with controlling for age, income, insurance, and comorbidities, that disparities still existed. And they concluded that health systems and providers are also contribute to these disparities. And while they couldn't definitively say biases played a role, they did think that provider bias and stereotyping may contribute to disparities seen in healthcare. And at that time, their recommendation in 2002 was increase the number of healthcare professionals from underrepresented groups, which I think is interesting looking at the data that Dr. Carruthers just presented, that we're actually the same or decreasing, if I'm understanding that properly. And they do think that looking at disparities should be a measure of provider performance. So in 2007, this was the very first test using the IAT. So the IAT came out probably in 1998 or 1999. And this was the first study looking at the IAT, and it looked at the prediction of thrombolysis in Black and white patients. We had providers, they had a case, a vignette of a patient with an acute coronary syndrome, and they took 3 IAT tests afterwards, and they were seen, and they looked at what happened. Now, just to kind of here, so if you're looking at this panel, this was specifically looking at race. And if you look at here, this is the low anti-Black bias versus a high anti-Black bias, and this here is for the Black patients. And what they found, physicians, I should say, or providers with a high anti-Black bias, were less likely to refer people for thrombolysis. And if you're looking at this last panel here, the composite panel, looking at everything, they found high anti-Black bias were less likely to refer for thrombolysis, with a low anti-Black bias at a higher referral for thrombolysis. So this was the very first study using the IAT. Now the question becomes, do we have any data looking at implicit bias in healthcare providers? So I'm going to go through a series of systematic reviews. This systematic review came out in 2018, and they wanted to determine if implicit bias towards racial and ethnic minorities were present in healthcare providers. They looked at 37 studies, over 10,000 providers across multiple specialties, and what they found is in 26 of those studies, most healthcare providers have some level of pro-white anti-Black bias, and most healthcare providers across multiple levels of training had biases against Black, Hispanic, American Indian, and dark-skinned individuals. They did state that these were mixed results and that these were mostly vignette-based. If you're looking at a broader level, this is another systematic review that looked now internationally. So they looked at studies in the United States, Canada, the UK, Australia, France. They investigated 12 biases inclusive of age, gender, comorbidities, along with race and ethnicity, over 15,000 participants, and their question stated, do trained healthcare professionals display implicit biases towards certain types of patients? And their measure included two things. They used the IAT and something called the assumption method. The assumption method is, I will give you a case, and everything in the case is exactly the same except for one thing, either the gender, the age, or the race of the patient. And any differences, any significant differences that are seen in management of treatment are assumed to be secondary to a bias against that particular variable in the patient care. And what they found is all studies found evidence of bias in physicians and nurses. They found a negative correlation between the level of bias and the qualities of care, but they also stated that there is a need for more uniform methods of research because all the studies they looked at had slight differences, so there was heterogeneity within the studies they used. Now the question becomes, we've identified that we have implicit biases as physicians. Does this affect our clinical decision making? Does this bias now come into how we take care of our patients? And this particular study, this is another systematic review, was done more in the ER setting because the feeling is, as Dr. Quezada mentioned, in the fast automatic thinking, that's going to happen more in a place where you have a lot of time pressure, you don't have a lot of information, you're fatigued, and you have cognitive overload. And the ER is a great place to look at this. So they wanted to see the relationship between racial bias specifically and clinical decision making, and they looked at all physicians and used their measure as the IAT test. And this 9 studies over the course of almost 10 years, over 1,000 physicians. And what they came to is, while implicit bias is common in physicians, the current evidence does not support the hypothesis that physician implicit bias impacts clinical decision making. And the question becomes also, does it affect decision making and does it affect healthcare outcomes? This is another study that looked at 4 domains in healthcare, specifically looking at patient-provider interactions, treatment decisions, patient treatment adherence, and patient health outcomes. And this was another systematic reviews. You can tell I have I'm going on a certain trend here. So looking at these 4 domains, in patient-provider interactions, they found that certain studies show that Black patients perceived poor treatment in patient-centeredness and communication. They found that physicians with an anti-Black bias were more dominant in their communication style. And physicians who had a pro-white bias were given lower scores by their Black patients in physician warmth and friendliness. Looking at treatment decisions, the results were mixed. They referenced the paper I talked about earlier in regards to thrombolysis. They looked at pediatricians and they found one study said, pediatricians do less than ideal pain management in their Black patients, but other studies didn't find any association. When looking at treatment adherence, one study found that there was a pro-white bias that was associated with Black patients being less likely to fill prescriptions. And just to clarify, if I didn't say, most of these studies were vignette-based, and then the physicians had to take IAT testing, and they looked at the responses of the physicians and their scores on the IAT, and that's how they correlated both of those things. But they didn't really find anything. They didn't find any significant association in patient treatment adherence. And looking at health outcomes, again, no significant association between implicit bias and health outcomes in terms of hypertension or physical health outcomes. Again, this systematic review also mentioned that this is a very difficult thing to test, and there really needs to be a lot more uniformity in terms of how the research is done. So the only interesting thing here that was quite significant, and this is something that came across in a lot of studies, is that the interaction, if there is a pro-white bias between the physician and a Black patient, the physician tends to be a lot more aggressive and less information sharing in terms of that interaction with that patient. Now, our surgical colleagues, does implicit bias affect surgical safety and outcomes? And if you're looking at surgical outcomes, specifically, we're looking at the decision as to whether or not to perform a procedure and the complications, success, and failures of that procedure. Now, the literature shows that Black and Hispanic patients are less likely to be treated with minimally invasive surgery, and they have some experimental studies that show white patients are more likely to be referred for renal transplant, just as Black patients are less likely to be referred for liver transplant. They also found that women and Asian Americans are less likely to be referred for renal transplants. So far, no association in bariatric cases, but the same thing that we found in prior studies, when there is a discordance or a pro-white or anti-Black bias that exists, the communication style between the patient and the provider becomes very different and is more aggressive on the side of the provider. So, this is a conceptual model I borrowed from a paper on weight bias, and I liked it a lot because I think it kind of really summarizes the issue here. If you take out the word obesity and say patient X comes in to see a provider, if that provider has a specific stereotype or bias against that patient, that might affect potentially the decision making on the provider's side, and that might affect that patient's outcome. If that patient then now essentially picks up on that attitude or that bias from the side of the provider, the patient might be less likely to be compliant. They might avoid care. It might cause mistrust in the provider, and that can affect the patient outcome. So in terms of a conceptual model, I think this really encompasses the issue very well. We don't have data that states definitively implicit biases affect patient outcome and patient care. You have some studies that say yes, and you have some, but most studies say no. But I think the consistent thing across all is that we need to have a more uniform way to really look at this issue, because it is limiting and challenging, because it's hard to see if, surgically, if implicit bias really plays a role. So what are the potential solutions? I think education is a big part of it. I do think, like all our departments, taking the IAT test is quite eye-opening. I think that we should have implicit bias training across all institutions, because that will help us regulate ourselves. I think we should promote equal treatment across all people. There needs to be education on cultural competence in a very meaningful way. We've done cultural competence education in a lot of ways, but is that meaningful and useful? We still have to look into that. And because the one consistent thing they found is the communication issue between physicians who are pro-white or anti-Black, the communication curriculum focused on patient-centeredness for students, residents, and practicing physicians might be very helpful. And there is one thing on mindfulness practices, essentially reducing the likelihood of activating your own implicit biases, also make you aware of your own biases and ways to mitigate that. And to kind of give an example of how the diversity culture affects everything, this was a study done out of Mayo Clinic. They looked at over 3,000 medical students across 49 US medical schools. And the objective they had at the time was, does a medical school curriculum, role modeling, diversity, climate, and contact with sexual minorities predict bias among graduating students against LGBT patients? And they did an implicit sexual orientation bias at year 1 and year 4. And the outcome measured was year 4 implicit and explicit sexual orientation bias. I will just review the findings on the implicit test. What they found, lower implicit sexual orientation bias was associated with more frequent contact with LGBT faculty, residents, students, and patients. Greater implicit bias was associated with more faculty role modeling of discriminatory behavior. So they concluded medical schools may reduce bias against sexual minority patients by reducing negative role modeling, improving the diversity climate, and improving student preparedness to care for this population. I think this is a very great example. In this case, we're looking at sexual orientation bias, but I do think if you apply this to any of the biases that exist out there, you can have a positive outcome. And this is early in the pipeline. You're getting students when they're coming into medical school and hopefully reducing certain implicit biases that exist. So in conclusion, and I will openly say these quotes are not my own, one is from one of my fellows and the first one is from a paper. Implicit bias among physicians and other healthcare professionals remain a persistent concern and a potential contributor to racial disparities in care. We cannot definitively link the two, but I think intuitively we know there is a link. Inherent biases, and this is from one of my fellows, built into our system which perpetuate disparities must be addressed, or our patients will continue to lose. Thank you.
Thank you very much for that talk, Dr. Williams. So at this point, I'd like to welcome any questions. If you have any questions, if you could please come up to the microphone up front here because this session is being recorded. And I guess before we take any questions, just another reminder that we have a reception to follow after this session in 6F.
Hi, thank you. My name is Pari. So I thought that was all excellent. One of my questions is, I'm very pleased to hear that all of your institutions have training on unconscious bias. And I actually don't know the policy. I don't know if my institution has universal training on unconscious bias, but I think it's a wonderful idea. So how does one, and many of our institutions probably, as you've shown the data, probably have male leadership or less diverse leadership. So what are some concrete recommendations you can make for how your institution might have gone about introducing this type of training? Or what are ways that we can, I could go back, for example, to my own institution and introduce this very important type of training?
Well, is this, okay. To be perfectly transparent, we just instituted the unconscious bias training at Maryland 2 years ago. When it was initially offered, it was exactly that. It was being offered, and then it was really just in the last 6 months that it became a requirement. It became something that was offered in large part because as we were undergoing preparation for our LCME accreditation, it became clear that we had work to do in our diversity and inclusion efforts. And so we actually had convened a diversity committee of faculty and deans and administrative leadership and came to the decision that we wanted to bring unconscious bias training to our institution. So we actually sent a team of trainers to be trained at the Cook-Ross, which is the AAMC organization in DC that provides this training. So we now have a team of 6 trainers at Maryland to be able to provide this training for our faculty. So I think that sometimes it takes that kind of impetus, but the good news is it's been very well received and people are really seeking it out.
At the University of Michigan, I'll say there's a couple of drivers. One was in preparation for LCME as one of the things, because that's in their mandate. The second thing is we have a president who came in 2014 and made 2 things his directives. One was to work on diversity of the institution, and the second was biological research. And with that, he put money behind really growing the diversity programs on the campus, which spread to the health system as well. And I'll say lastly, you know, as a chair of medicine, my dean puts in my incentives that I make sure that these things are carried out.
So, hello?
Yeah.
I guess it's not on. So it's not a requirement with us. What happened, we have a diversity board in the Department of Medicine that I now chair, and the prior leadership brought it up as an important thing to do. And we said, and we went to the chairman of medicine, so I think it's important to engage your stakeholders, your major stakeholders, and we said this is important. We have a very diverse faculty. We have a more, I guess we're diversifying our students. We need to make sure that everyone gets implicit bias training. And then it came from the chairman of medicine, who's also the vice dean, that then said that every division within the Department of Medicine had to get implicit bias IAT training.
I also just want to add one thing, that because we've referred the LCME accreditation, but those same mandates in LCME have now been added to ACGME as well. So I think we're going to see a lot more activity on that front for our fellows and our residents as well.
Hi, my name is Alok Patel. Thank you so much for talking about this, because I think it affects everyone in medicine at every scale. So I'm not trying to get political, but I have to ask. So there was a slide about the sexual orientation and saying partner, whether it was Jane or same sex, and showing that there may be a little bit of a bias. I noticed that the article that I was referencing was from 2002. So I thought to myself, I said, well, hey, you know, we've had a lot of progress. in the past decade and a half. So maybe if that study was replicated, it wouldn't show the same result. But I had a conversation with the CEO of GLAAD, Gay Lesbian Alliance Against Defamation, and she actually felt that in today's time, people with extreme views may be a little bit emboldened by our political climate. They may feel, I don't want to say safer, but they may feel more comfortable in having a bias. Now, when I was in medical school, we never touched politics. It was taboo. Do not dare talk about anything happening in the news. But I feel like now, at every stage of medical education, we almost have to. And even if our institutions say, like, please don't bring up politics, I personally find kind of walking a fine line, but I feel like if we don't speak about it, the media is. And so things that we're fighting against with journals, they don't actually get to the masses, and patients are coming in there, and patients have their biases because we're not speaking out, and they're saying you're not supposed to address this. And we had a huge situation in my residency with a patient who actually refused the care of a colored resident. And there was a split in how to handle it, which is not acceptable. So my question is, do you feel like it's okay for our programs to start talking about the political climate and to address these topics head on? Because I feel like we have to.
You know, I think it depends on the culture. So, for example, at NYU, when our current president made some comments about certain countries, the vice dean sent an institution-wide email saying, we do not support this in any sense. And we had a similar situation happen where a patient came in and said, I don't want to get treated by a person of color. And that patient was a VIP. They were told, then you can't get treated here. This is your doctor, and that patient left. So our institution has a very, very strict line. We have policies in terms of discriminatory behavior from patients. And if that happens, we tell the patient, assuming they're not obviously it's not an emergency, that you cannot choose. And if you choose to go to another institution, then so be it. So we are very strict on the fact that we do not support certain things when it comes to discrimination, and that's from the highest level.
I would agree with that. I mean, you have to be above the politics. What is the mission and values of your institution? What's the mission and values of your departments? And those have to be upheld. We've been in politics since the country was founded. There's been extremes and before and now, and maybe even now too. So yes, it does influence people and it maybe emboldens certain groups. But I think if you look at our caring of patients, the type of people we want to hire, you have to be above that and follow your own values, irrespective of the political climate. It could be a reverse. It could be a very liberal government and have biases versus a conservative government. So it could change. It could swing in 5 years. So you have to look at what's the mission and values of your own institution. And I would agree with Renee that you have to uphold those.
Hi, everyone. I'm Jennifer Christie from Emory University in Atlanta. Thank you for your wonderful talks. We don't have a mandatory policy for unconscious bias training, but we felt that it was important for our division, so we did a grand rounds on it. And what I learned during that grand rounds was there was two groups. There were a group of folks who were like, we don't have this problem, it doesn't exist, didn't really understand it, why are we doing this? And then there was another group that said, this was great, this is a great way to start the discussion, now what, right? Because you have this training, and now what? How do you continue the discussion? Because it's not gonna be fixed in an hour. So I would like to hear what you guys are doing at your institutions to continue the conversation.
Well, so I'll add that I think that that's a challenge that we all are working with. One of the approaches that I've taken is to start with the training, which again is required, but then to follow up in the form of a grand rounds or even a discussion, maybe a session with residents and fellows or with faculty, to do some of the things that what I was doing in my initial in my presentation, with just coming up with concrete examples and looking at, let's take a look at our list of the speakers that we've had over the last 10 years, or who, or we could do this within our organizations here, in all the organizations represented at this Joint Society Symposium. Who are all the people who have received awards and recognition? Do we notice some trends here? And just have some honest conversation. Sometimes I think some of the things we talk about can be so conceptual and almost abstract, and then they need sort of that real concrete day-to-day example to be able to appreciate those nuances and then pick up on the conversation following that.
I think things take time, as you mentioned, and are incremental. You're right, we're not going to stop on a dime and change the world in one day. But these things add upon each other. For instance, so keep reinforcing. The more diversity you get, the more ideas you'll get over time. So if that continues to grow. I'll just give you one example. So we decided to name some names of senior faculty to be within an internal endowment. So I put out an email, I don't know, about a week or two ago about this, and this is the second year we've had these. And I remember when we had the discussion about a year or two ago, and I was asking some of my associate chairs, like, who should we name? And they said, oh, name him after the former chairs of medicine. Well, all the former chairs of medicine were all white men. Okay, nothing wrong with them or anything, but I'm like, well, I don't like that idea, so I had to convince them that we should do something different. So I came with the idea, let's honor some of our more senior faculty, our diverse faculty. So last year we named 3 of them, 2 were women, 1 was a guy. This year we named 3 more, 2 of the women, 1 the guy. We have more women now named with these than guys. And so this again, just takes time, and I think it's all incremental. And so you just have to keep doing it, and it's not, one-time thing is not going to fix it, but you gain 1%, you gain 0.5%. It's like recharging your phone. You start at 2%, when your phone runs down. It takes a little while to get up to 100%, and it might take, several years to get to 100%.
Thank you.
Joan Culpepper Morgan, Harlem Hospital. Wonderful presentation, so important. One of the things I wanted to go back to was the pipeline. I'm very concerned that the solution to bias and disparities in healthcare is diversity in the workforce, but yet the diversity in the workforce seems to be going in the wrong direction. Do you, sort of our experts here right now, have any ideas as to how we can reverse that, specifically at the level of training of gastroenterologists? Are there any tips or tricks or things that we can do with respect to recruitment and retaining that will improve and increase the diversity that's needed to overcome some of these biases and disparities?
I think it's interesting. So last year, as you mentioned, the ACGME, as of June, now states that we have to have a structure in place to recruit a diverse training force. And I think that will spur a lot of different programs into being more systematic. We have to make a really big effort to recruit. Part of that is when, I think you mentioned, having a positive experience in your interview day. So I do recruitment for the Department of Medicine, and I make sure that every diverse applicant that comes in is interviewed by a diverse faculty member, because that does make a difference. People aren't going to come to your institution if they don't see people that look like them in some manner. And I think we have to really look at it long term and say we need to make sure that people see and they know that we are an inclusive environment. So I don't think it's an easy solution. I think it's hard. And as you go, from residencies to training programs, the pool gets less and less. But we have to start in the pipeline very early on to try and get more people into the STEM fields, starting from high school, from colleges, and then hitting medical school and recruiting patients into GI to say, hey, listen, this is a great field, and understand that we need to diversify it. So I make a big push for more women in GI and more underrepresented groups in GI. But again, at our level, the numbers get very small.
So I want to echo what Renee says. So first I'll say this in 2 parts. One is the people who've made it to a certain level, trying to get them promoted and stay in the system. I showed you some quick data from the American Journal of Surgery article. And the pipeline's small. When I looked at the MD PhD students, this was 10,000 MD PhD students since 1975. There were 300 African American in that whole entire group. So you do have to go earlier, because by the time they get into GI, there's a small number, and the data hasn't changed in the last 10 years. It's hugging 0 or a few above that. And then we're trying to get those few people in through the process of fellowship, training, faculty, or whatever they're doing. So how do you get the pipeline? And so you gotta show excitement about going into STEM fields, becoming a physician. So how do you do that? And that's something that's probably beyond what we can do in this room. We can once they get into the level of training, maybe we can do something if we're really, dogmatic about it. So when I was here at UCSD, I was on the faculty here for 15 years. The former provost wanted to start a high school on the campus of UCSD, and it was voted down by the faculty. But the chancellor was very smart. He wanted it to happen. One of the regents at the University of California wanted it to happen, and he wanted to give the first $5 million for it. He was a very wealthy regent. So there was a process he did. I was an assistant professor at the time, but I got on this committee, and that's what launched the Preuss School. But we did tell the chancellor, we don't think you should put a 9 through 12 school on the campus. You should put a 6 through 12 school on the campus. And ultimately, that's what happened. So the Preuss School was born 20 years ago, or 20, 25 years ago, on the campus of UCSD in La Jolla, where the minority population is small. And these people, it's a public charter school. The kids are bused in from south of I-8. You can't use race. It's not an affirmative action. There's a state law about that. But they have to be first generation, so my kids can't even go to that school. And you have to be below a certain family income. And there is a waiting list to get in there. And the goal was to take these kids who were in schools that were having 8 to 10% matriculation rate to college to make them eligible for the University of California system. 92% of those kids go to college. 60% go to the University of California. The other 30% go all over the country. And these are public schools public kids who would probably not have gone to college otherwise. But that's only a small piece of the entire population. We need to amplify that like 50 million times. But I think it does start at a younger age to get them excited.
I do want to just throw in, because I'm the Associate Dean for Admissions at our medical school, and so I absolutely agree 100% that we have to start way earlier, because the medical school applicant pool, while has achieved gender parity in the last 15 to 20 years, hasn't budged at all for our Black applicants or Latino applicants. It hovers at about 6 to 7%, so single digits even at the medical school applicant pool level. So clearly we need to be putting efforts in place much earlier than college. We need to be going to high school, middle school even. And I just would add that I 100% agree that it's important for, even at that level, for young people to see mentors and role models that look like them. At the same time, though, I would argue the onus is not only on our faculty of color or our women faculty, and that everybody needs to value this and appreciate how critically important it is, and reach out to these young future physicians and support them and mentor them.
Yeah, on that note, for those of you who know me for social media related work, I just want to recognize, I know there are some of my friends and colleagues in the audience who are actively using social media to showcase what they're doing as gastroenterologists to inspire younger generations and sort of meeting them where they are and doing that sort of outreach. So I think that with future generations who are, thinking more about this actively, I think that maybe we could, and inspire some change. So we'll take the final 2 questions.
So I have a comment, Matt Walsh from Cleveland, and a question. So the comment is, I think the discussion afterwards is just as valuable as your great presentations. And I would also note that this has been a combined symposium for a couple of years, and it grows every year. And I would just admonish you to bring 2 or 3 more friends next year, because I think the discussion is great, which will continue afterwards. My question is, we are very highly metric-driven people, whether it's adenoma detection rate or RVUs. So is institutionally, at the institutional level, are you measuring that you can overcome unconscious bias or inclusion more than just diversity?
So as I mentioned, our president of our university, so the great thing is that the president's saying we got to do this. So that's good. And so they have a whole office that is tracking this. Now, it may take time. So, after 2 or 3 years, you might see a little bit blip, hopefully. And they're measuring things like faculty retention, faculty recruitment. So not just everyone taking the training, but the breakout of committees and those types of things. So there are measurements from our undergrad and graduate diversity offices that they are tracking. And as I said, I put on my own chairs list now our grand rounds. I don't do every division's grand round, so I hope my division chiefs are doing that. But I do track the breakout of our faculty, and then I help set the search committees for our division chiefs and those types of things. So I am tracking it on my scorecard, and I believe the president and our diversity office is doing those types of things at the institutional level.
Yeah, I am actually not sure if our diversity office is tracking certain metrics. Within the Department of Medicine, we do track our recruitment of diverse residents over the years, and we break it out based on tracks. So we go back probably the last 5 years to see who recruited, and we also look at who stays. But I'll say I'm probably 90% positive that our Office of Diversity Affairs might be tracking some metrics, but I don't think we're looking at more diversity, not looking specifically at biases. So that's actually a very interesting thing to think about.
All right, and one final question, and just a reminder, our reception is next door, I believe, in 6F. Yeah. Oh, down the hall.
6F.
Down the hall, 6F. All right.
Joanne Wilson, Duke. I actually am very happy to see this incredible outpouring of people involved in diversity, because I was chair of the diversity committee for the AGA some 25, 30 years ago, something like that. I wanted to make 3 points and in part questions. Number one, that diversity committee years ago looked at the percentage of African Americans in medical residency programs as compared to GI programs, and there was no loss, no drop in the percentage. And looking back at where we lose, there is an endangered group. There are almost no African American men of slave descent in anything in medicine. I mean, it is appalling when you look at those numbers. Secondly, the fall off is from, I call it algebra. That's always been and I just recently was documented, that's 6th, 7th grade, so your point well taken. At Duke, we've had a couple of programs. The recently deceased Brenda Armstrong had a summer program called the Duke Summer Medical and Dental Program for college students in order to try to get them interested to pick up there. And they were picking up, again, disadvantaged students. So there were some kids from Appalachia that were of multiple ethnicities, and first-generation kids and so forth, and African-American kids, to try to get them interested. But again, and that uptake was near 100%. It's only 90% of those kids went into a science field. I have lectured in that program for 14 years as free lecturers, got my fellows that were minority fellows to also work in that program. And so that has been really important. And then our SNMA went out to the high schools and started a high school program. Again, it's a bit late, because if you haven't gotten into the sciences in high school, you won't make it. I mean, and it's just so sad. Once for the AGA, we decided when we went to a city that a series of a group of the African American gastroenterologists would go out to the schools, the predominantly underrepresented minority schools, and talk to students. And we did like a sort of a health fair type thing. This was many years ago. And, you know, those were little things that we did. And so there are small incremental opportunities, but again, we can't do it, women and underrepresented minorities. It has to be embraced by everyone. The second point I wanted to make was our group, like our institution, likewise started the unconscious bias, and GI has been one of the leaders. We actually had a person come and do grand rounds with us. But the bottom line is that you don't eliminate unconscious biases. They don't go away. You can only recognize them, as you said in your talk, and I think that's key. The third point is that we have formed a diversity committee within GI, and it was prompted not by problems within, but patients denigrating physicians and so forth. So we actually determined that there was no document or anything within our institution that said you have to respect the doctors. You cannot decline to see a doctor because of race or ethnicity. And in the case that we addressed was actually ethnicity and not race. And so I wondered if also we have taken a stance on that because you get a diverse population into a specialty and then you have patients saying they won't see. We're actually going to have a sort of a placard up in all of our clinics, and we're trying to get the whole medical center to do the same thing because we're in the South, and so we have our physician population is more diverse than, say, a lot of other areas that patients see, and so to have that as a counter, and I think one of your diagrams said it goes both ways with the biases. But thank you so much for your presentations.
Thank you for